the original name of schizophrenia was dementia praecox, from the cognitive impairment seen at such an early age. They didn't call it schizophrenia in those days. They called it dementia praecox. Very interesting aspect. It's fascinating to read those literature. Okay, these are some of the genes that have been identified with schizophrenia, just to let you know. And then this, of course, some of the potential effect on neural transmitters in this aspect. So when you look at the model, I flipped it around this way. You have those neurodevelopmental factors. Your first things that you see are cognitive impairment. The cognitive impairment and the grades going down or whatever in the high school time could be related to various neurotransmitter functions. Mainly, the one we'll talk about is dopamine, but we know that serotonin, glutamate will also be involved, as Dr. Emmett and Dr. Pong will talk about. And then, when you have the cognitive symptoms, you also have mood disturbances. You just don't have schizophrenia. They get depressed, all that sort of thing goes on. Suicide is actually quite high and prevalent amongst patients with schizophrenia. Okay? And then, here are your antipsychotic drugs as well as your atypicals in this aspect. Typically, when you begin treatment, you look and hopefully impact the positive and negative symptoms. So then, of course, what we monitor is a person's behavior and their thinking and what they say to you. So you can see it's interesting how where drugs fit into this whole model of things, that a drug, if we're looking at, should not just address the positive symptoms of schizophrenia, because obviously they are the most disturbing, but you have other things that are associated with the disease, from being negative symptoms, cognitive impairment, and mood disorders. You can see it's a very fascinating compendium of symptoms that we have. And so what we see here in a developmental sense, when we look at premorbid, you see childhood to early adolescence, again with neurodevelopmental. You look at motor coordination, mild cognitive impairment, some social deficits, that sort of thing that goes on. You have to start thinking about, something may not be quite right with this young one when they like to kill animals and torture them. That's when you have to start thinking, there's something going on not quite right. They need evaluation. Those are things you start thinking about. And then they call the early phases that haven't been diagnosed, as we talked about around the 15, 16, they call that the prodromal phase, okay, as they develop, looking at family history and all those sorts of things that as a person progresses. And you can see that is where the cognitive impairment, some of the early mild cognitive symptoms come into play, mild psychotic symptoms. Sometimes magical thinking is part of that. So those are things to think about. Social withdrawal, those things that are commonly seen in the prodromal. And then obviously when it is recognized, onset, and the patients don't do well, and then they of course need treatment, and then where you have more psychotic symptoms in that aspect. And then your chronic, when they're out several years to 10, 20 years, is your chronic residual type. So you can see that symptoms will always wax and wane. So they get better, medication, then they could have a breakthrough episode, may need a higher dose, they may stop their medications, whatever, all those things of real life. And if you think about being treated with a lifetime with these drugs, given all the side effects we'll see on Friday, you could see that all of a sudden, you've got a very challenging course of therapy for these patients. Now, in the far right column is when you see some sort of correlation with pathology and the brain. And we'll show you some pictures because people have tried to look at, say, a specific part of the brain that causes schizophrenia. We don't have that yet. It's not like Parkinson's disease, that kind of thing. Schizophrenia is a multi-brain type function or dysfunction in this aspect. Okay? So, here's the clinical presentation. As mentioned, there are three. I did not put up the affective stuff because that's mood disorders. We'll talk about mood disorders with Dr. Cohen in that particular aspect on Monday. But don't forget it, okay? But the three symptoms that we look for in schizophrenia, besides the affective, positive symptoms are what we designed the antipsychotic drugs initially for, because it's the delusions, hallucinations, all that sort of stuff that will demand treatment. Okay? So catatonia, just as a person shutting down, the catatonia is also the opposite, meaning that the person is so excited and out of control that you have to treat them. To the point, to give you an example, I had a psychotic patient, thought that God was chasing him and wanted to kill him. He would run full force and ran into the wall and left parts of blood on the wall. That's how hard he hit it. And it would splat. He'd turn around and run to the other side to the office, splat against that wall, and just back and forth. We had to shut him down, and literally sedate him with antipsychotic drugs so he wouldn't be harmed himself, that kind of thing. That's the other flip side of catatonia. Okay? So those are the positive symptoms. The negative symptoms are a little more insidious, okay? And also can be more difficult to treat with a drug, okay? So diminished emotional expression. They're very flat on their affect. Evolution, alogia, lack of words, anhedonia, asociality, the withdrawal. That could be a tougher aspect for drugs to treat. But those are also well recognized. And if you want to think about it from a symptom aspect, anything with these A's, negative symptoms. Okay, that you can also group that together. Okay? And then cognitive thinking, impairment is exactly what it means. And I gave you some examples of that work. Working memory, abstract abilities. It's okay. If you can't answer a proverb, you don't have cognitive impairment. All right? So don't feel bad. So anyway, we also talk about difficulty understanding interpersonal cues. You know what that means? If a person's mad at you, you don't realize that they're mad at you. Like, they want to beat you up. You go, oh. And you say, hey, how are you? Let me shake your hand. The guy might just turn on and just belt you. That kind of thing. Those are the things to think about. Okay? All right, so the negative symptoms, as I mentioned, this slide explains it. So those are the things you think about, and you can actually monitor that quite effectively. Again, the PAN scale does pick up on that. And so, again, this could be very difficult and one of the more challenging things for a drug to really improve, because it's sometimes not as noticeable. You always can notice a hallucination when it stops, right? A little bit tougher to get a person to speak more to you when they don't want to sometimes. Okay? Give you an example. All right? All right, so when you think about schizophrenia, you have to look at all these aspects in which a drug has to try to move. And it's not going to move them all to the same degree, right? Sure, you want a drug to improve the hallucinations, but it may not do much for disorganized speech or their speech patterns, okay? Or it might not help with their behavior if it's disorganized, okay? That sort of thing. Or some delusions may not go away. If a person really has a fixed delusion, drug may or may not make it disappear. In fact, most often it doesn't disappear. They may not tell you about it. Patients with schizophrenia also know what to say to get out of the hospital. Remember, they may be psychotic. They're not dumb. Okay? They've learned to survive on the street and all that kind of good stuff. Okay? So, to give you an example, the fellow I said was Napoleon. Well, 2 weeks later, after he's been on medication and treatment, I went up to him and said, "Hi, Mr. Smith, how are you?" "Oh, I'm fine. Do you still think you're Napoleon?" "Oh, no." He still had his hand in his shirt. "So what are you thinking?" Right? So, okay. So, those things to think about. We mentioned about the cognitive and the negative symptoms, and of course you look at their sleeping. They're sleeping at night. Sleep is underrated, right? Even for patients with mental conditions. Everybody needs sleep. It's typically disturbed in a lot of our different mental health conditions, okay? And of course you go for the person's mood, as mentioned already about suicide and all those wonderful things. So you got to look for a drug that's affecting a lot of those aspects. So, let's try our next question. Which of the following known as a negative symptom? I'm looking for 100%. almost 100%. 95%. That is correct. One, the hint, letter, what letter we look for? A, right? Okay, is one thing. Disorganized thinking is really not part of that aspect. It's more could be associated, not necessarily even with a positive symptom in this aspect. It kind of stands out there by itself in this aspect. Working memory, I'm glad no one picked that one. So we're good shape, pretty good shape. Okay, now structural abnormalities. People have looked for structural abnormalities. This has been what reported in the literature. Doesn't mean it's the hard fact. It's just people what they report in the literature. They noticed some anatomical abnormalities, such as larger brain ventricles. Okay. Hippocampal changes, involving because of memory type stuff, but we'll see more. Hippocampal changes is really associated with Alzheimer's disease, that sort of thing. But they do notice also a decrease in whole brain volume in both gray and white matter. And part of that, they're thinking that if the brains do actually shrink in schizophrenia, that could be a cause of part of the neurotransmitter difficulties that it has, and part of that perhaps neurodegeneration hypothesis. So they have measured it. These are the things that have been observed and reported in the literature, but that is not a diagnostic tool of schizophrenia, okay, in this aspect. Most prominent theory involves various neurotransmitter system abnormalities, which we'll go a lot more in depth, and then finally we'll wrap up with inflammation and the immune response. Okay, so here's the brain. I love this picture. We have different parts of the brain that do different things, okay? And when we think about various aspects, Drs. Pong and Emmett will go a little more in detail about, because actually the pharmacology of drugs is the affective systems, but we have the basal ganglia, which is a movement aspect of dopaminergic dysfunction associated with antipsychotic drugs, right? We already talked about basal ganglia as a part of the Parkinson's effect. Well, basal ganglia effects also have lots of other movement disorders from antipsychotic drugs. Okay? We'll talk more about that. The frontal lobe. When you make a fist, that's your brain. Think that very front part, that's your frontal lobe. Frontal lobe is your CEO of your brain. Okay? CEO of your brain puts all your thoughts, emotions, logical thinking, all that stuff together for your thought process. So obviously in schizophrenia, that's not working so well. Okay? And just think about people who take a few blows to that area, like in boxing or like football, that sort of thing. Those are things about. That's why you have some of the cognitive impairment from injury like that, okay? Limbic system, disturbance in thought. I love it. It says contribute towards that magic word, agitation. They think that's where agitation comes from. Okay? And you look up here, auditory system. It's, again, when you're hearing, and they think it's the interpretation of auditory hallucinations. You have this part of the brain here, occipital lobe, and processing the visual world. Again, some of your visual disturbances, perceptions. And, of course, the hippocampus, learning and memory, as we mentioned, okay? Now, there are some of your scans. This is one of your SPECT scans. They do notice in brain function that when you look at the cooler areas versus the